May I invite the next speaker onto the dais, Dr. Sandeep Nayak, Founder and Chief of Department of Surgical Oncology, MACS Clinic, Bangalore.
Good afternoon. On the outset, my sincere thanks for the organizing committee for having invited me here. It is Calicut is where I learned thyroidectomies, and my teachers are sitting here. And Dr. Srijayan, who spoke before me, was one of the persons who really started my interest in thyroid. So he was the one who actually showed me a lot of thyroids those days. And I think, when I saw his presentation, I was really inspired, and I was looking at what I learned those days. So today, standing here, I'll be talking about robotic thyroidectomy and the journey that thyroidectomy as a procedure has had, and the robotics in thyroidectomy, what difference it has made to the patients and to the surgeon. Now, I just wanted to show you this. See, the thyroid diseases can be identified in the images which were there about 5,000 years back plus. And some of the first thyroidectomies happened in 900 AD. But if you look at this, this is one marked in red is an important landmark when French Academy banned thyroidectomy as a procedure. The reason was the mortality was 40% plus because there was no hemostasis available. And until a hemostat, the humble artery forceps and the mosquito forceps that we use were invented, thyroidectomy remained banned. It took 50 more years for it to be accepted as a standard procedure, and then in 1909, Cocker got the Nobel Prize for it. So it has had a very long journey. In fact, like many other things, the evidence has been oscillating from being safe to unsafe to better to, and this way and that way. So it does happen in science. So there is no absolute. Today what is unsafe can become safe tomorrow. Now, what are the key things in thyroid surgery? When we perform open surgery, 100% of them have scar. But what is very important is the next complication, which is the hypocalcemia, which is about 6% in the world literature. And the recurrent nerve injury comes as the next important complication. So the entire thyroidectomy, if you ask me today, is about avoiding two complications. One, the hypocalcemia, that is permanent hypocalcemia, and two, it is a recurrent laryngeal nerve injury. Now, I remember one of the patients whom I had, assisted, I think, I don't remember which unit where, but it happened in Calicut Medical College. I remember that patient committed suicide because of hypocalcemia, persistent hypocalcemia. So I still remember that instance, and that is something which always is very important when you perform every thyroid surgery. Today, Dr. Srijayan showed you how it can be saved in open surgery very beautifully, because the landmarks are very good. Even if you save one parathyroid, it really makes a huge difference. Now, coming to this first thing which I told you, the problem of thyroid surgery, the scar. So this is the first attempt at avoiding a scar was made in 1997 with an endoscopic thyroidectomy. Then when Robo came into practice, 2007 was when first robotic thyroidectomy was performed. That was by Chung from Korea. And that technique of transaxillary thyroidectomy is still persistent, but it's a gasless technique. So the entire idea of doing this, or doing the thyroidectomy by minimal access or using minimal access technology, was to avoid a scar in front of neck. Now, look at this very interesting paper. This is a very nice paper recently published, which talks, this is 2018 actually, has compiled the techniques available for minimal access in thyroidectomy. Whether you call it minimal access or remote access is a choice which is there, But some of these are minimal access, like the trans-oral or retrovestibular and Baba technique. All these are minimal access, whereas the transaxillary and retroauricular, which is predominantly robotic technique, are actually the remote access, basically to send the scar in areas which are hidden. So that is the idea. Now, when I started doing robotic surgery, when I had access, I didn't have the specialized retractors which are required for this. So I had to think alternatively, and that is when I looked at the, what can be done. So all these techniques actually require specialized retractors. There is a reorientation of the anatomical landmarks that is required, because you are transoral, you are looking from up down. So there are a lot of orientation issues. The wounds are large. In fact, if you have to do a total thyroidectomy transaxillary, or you have to do it from retroauricular, the wounds are quite large. In fact, if you do bilateral, in fact, it's very difficult to convince a patient. I can't convince my patients if I have to do it. So, and this retrolabial or transoral technique is predominantly for smaller lesions, and going laterally and performing an extensive neck dissection is very difficult. So this is basically to show you the difficulties, same things which I already told you. But when I started doing, this is what I changed. This is the technique which I called rabbit, robotic assisted breast axilla insufflated thyroidectomy, which is a modification of Baba technique of endoscopic thyroidectomy, wherein we use 5 ports. One of this is assistant port. I'll show you the port position. Yeah, this is the flap which we use, raise, and this is the primary port, and this is the space which we create by open technique, that is using this retractor. 3 ports are placed. After this, we can create rest of the planes using endoscopy or docking the robo. 2 more ports, and then we can dock. This is the thyroidectomy. The approach is exactly like open surgery. So if you see, we go in the midline. You can see the 2 heads of sternomastoids on either side. These are the strap muscles. We divide the center midline, go into the investing layer of the pretracheal fascia, and that is the thyroid. See, the third arm works like the assistant. So third arm retracts the gland, again very delicately, because we can't cause any trauma. You can see the middle thyroid vein over there. This is the right side. Every time we approach from the right side itself, so you can see the strap muscles being lateralized. That's the middle thyroid vein. So once the middle thyroid vein is cut, this is exactly the open surgical technique which I was taught by my teachers. So we go into the tracheoesophageal groove. So that is the tracheoesophageal groove. See, most of my patients are malignancies. As an oncosurgeon, I deal, 90% of my cases are papillary carcinomas and such cancers. So I have to do an proper dissection, and I can't go subcapsular in many situations. So that is the superior pole of the gland, or the superior pedicle. We identify the artery and the vein separately, and most of the patients we can identify the external branch of the nerve because of the magnification, external branch of the superior laryngeal nerve. So retracting, we see the tracheoesophageal groove again. This is the parathyroid mound, where the parathyroids sometimes can be 2, sometimes it can be a single mound which has both 2 parathyroids. Now dissection around this area has to be very meticulous. We can't use too much energy. So you can see the planes are developed meticulously. You can see the terminal branches of the inferior thyroid artery over there pulsating. That is the terminal branch of the inferior thyroid artery, one of the branches. So as you go down, you can see the recurrent nerve over there. So those are the arteries, arterial branches. Nerve is already exposed. So that is a parathyroids, 2 parathyroids. You can see the recurrent nerve. Indocyanine green is used to make sure that the vascularity of these glands are intact. So that is a recurrent nerve, laryngeal nerve entering the cricothyroid membrane. You can see the point of entry. And the arborization of the nerve. There are 2 branches you can clearly see. That is a Berry's ligament. So once the Berry's ligament is cut, the gland immediately frees up. So same way, once we finish this, we tuck the gland into its place, the lobe into its place, and move to the opposite side. And see, this entire procedure is happening from the same docking. We are not changing the position, we are not shifting to the opposite side. So we start from the same side, we can complete the same procedure through the same approach. Very little of this video is left. I'll just show this and I may have 1 or 2 slides after that. See, here the recurrent nerve again can be identified in the tracheoesophageal groove. See, that is a recurrent nerve. And the parathyroid is here. See, you can see the superior parathyroids over there. That's the superior parathyroid. See, even if you see that the parathyroid is devascularized on table, if the tissue continuity is intact, it's better to leave it there. So generally, though we check it, so this is the superior pedicle. I'm not able to forward here. So this is the superior pedicle, and you can actually on this side clearly see the external laryngeal nerve, the external branch of the superior laryngeal nerve. If I could show it, I could have. Yeah, that is the nerve. Yeah. So once that is done, the gland is separated and removed. Now, see, with this technique, we can perform complete bilateral neck dissection and the central compartment as well, and the entire specimen comes through a small wound like that. But what also I wanted to convey, can I just take, use the time, yeah? So see, this is, using autofluorescence for identifying parathyroid. This is done using, a specialized camera, but this is a highly enhanced image. You can see 2 parathyroids, but in normal light you cannot see this. This is using autofluorescence. But what we generally do nowadays is identification using indocyanine green during robotics is once you make the area, clear the area, we give indocyanine green, and the first structure to light up is the parathyroid gland. The 2 glands which you are seeing on the left side, they are the first structures, the first hit hypothesis is what it is called, and we can identify and preserve it, and at the end, once you preserved it, you can confirm that the vascularity is intact. So you can see the blood vessels going there and vascularizing. So this way you can avoid an hypocalcemia episode for the patient. The main thing about robotics is magnification. This is what makes the difference. I just wanted to show this video where we had a situation where the recurrent nerve was not identified, but there was this is a non-recurrent nerve which happened, and the magnification and the meticulousness of robotic surgery does help for everything, whether it's open or robotic, it is important, but then I just wanted to show this recently which happened. You can perform large glands, it's possible with robotics. And what is interesting is we can avoid a thoracotomy when there is an extensive extension into substernal area. So that's the importance of robotics. We can do video-assisted robotic thoracoscopic surgery. So again, in children, we can avoid scars. We can do the extensive lymph node dissections, bilateral neck dissections, central compartment with the same technique. So what I am trying to draw today is, in future, I feel robotics will be part of every surgery, whether it's open or minimal access, because there is an advantage of magnification. Surgeon gets 3D vision, a wider vision, because with the smaller wounds you can see much wider, much more, and better control on vision is there. And fluorescence, of course, adds a lot to the saving of structures. Newer dyes are coming. So that is my conclusion, and I would like to welcome you for National Conference of Indian Association of Surgical Oncology in Bangalore, which will be in September, and this is my team. Thank you very much.
Very good presentation.
Thank you.
Any question from the audience? Very explanatory also.
So what is the cost of this surgery?
Oh, so it depends on multiple factors. It depends on the ward and all that, but generally,
Average cost.
see, if it's a general ward kind of a category, I think we have around 3 lakhs is what we would be, coming, because robotic instruments will come to around 1 lakh.
The time taken, sir, between the open and the robotic thyroid?
See, depends on multiple factors again, because size of the gland and all that. But see, once I sit on the console, I take about 45 minutes.
Thank you, sir.
Thank you.